Okay. While sitting here, I just realized that I am putting so much medical jargon into my slides, and I can see my nursing colleagues who are not used to outpatient hematology. Nowhere does this slide say about chronic myeloid leukemia. Nowhere does it say about TKI. My apologies. I'll have to explain myself first. So basically, forgive me for sounding a bit patronizing, but this is for the benefit of our colleagues as well. Chronic myeloid leukemia was a scary disease until like 2 decades ago. People used to die quite frequently with it unless they got an allogeneic transplantation. Then came a wonder drug called imatinib, or tyrosine kinase inhibitor, which changed the landscape of chronic myeloid leukemia. Then it turned from a killer disease into more like a chronic disease, and you take this pill every day, and most of the people would live a very long time. So the talk is about if we are able to stop this medication and still keep the patients in remission, and what is the long-term impact of this approach. So TFR stands for treatment-free remission, which means you stop the drug and still remains in remission. Before going into that, we'd like to remind ourselves about the molecular testing for CML. This is done by peripheral blood. And there is an international scale that we use to report the BCR-ABL molecular quantity. And as you can see on the left side, when the patients present to us for the first time, they usually have near 100% BCR-ABL positivity. And then as the treatment progresses, they drop it to 10, and then 1, and then very low levels. The physician colleagues are well accustomed to these terms, but I'll just remind myself and others, MMR, or major molecular response, corresponds to MR3, or 0.1%. MR4 corresponds to 0.01%, and anything below MR4 is considered deep molecular response. And nowadays we are able to test up to MR5 and detect levels below it. Okay, so we have guidelines, mainly the Nccn Guidelines, which was updated in March this year, and the ESMO Guidelines, which was updated in 2017 to guide how and when to stop TKI and how to monitor them. There were earlier suggestions from ELN and this beautiful paper by Hughes and L in Blood in 2016. But we'll just have a look at NCCN and ESMO and compare what we have to do to consider and stop TKI. So if you have chronic phase CML and there is no resistance and you have a measurable BCR-ABL, and you have had any of the TKIs for more than 3 years according to NCCN and more than 5 years according to ESMO, deep molecular response of less than MR4 according to NCCN and less than 4.5 by ESMO, which has lasted for more than 2 years, you are eligible to stop the drug or trial of the discontinuation. So as you can see, the NCCN guidelines are much more easy to do because you only have to wait for 3 years of TKI with 2 years of less than MR4. We'll look at the trials and the evidence later. So most of the TKI discontinuation trials, you can see that the success rate lies between 40 and 70%. So more towards the 50% mark, most of them. whether it is first generation TKI stoppage or second generation. If you look at the tops, so this is a compilation of trials on the NCCN website. If you look at the first trial on the list, which is STIM-1, this trial was the first trial, and it had the most stringent criteria. So you had to have undetectable disease of MR5, so undetectable disease for 2 years, and treatment would have to be restarted as soon as there was detectable disease. So the trial was very stringent, and you can see in the last column, the TFR success rate was only 38%. And this was true for the Australian Twister study as well. The first 2 trials had the same criteria, very stringent. Coming down, when we reach ASTIM, the criteria has changed. So you only need MR 4.5 for 2 years, and you only restart the drug when you lose MMR. And you can see that the success rate now has improved from around the 40% to 60%. So it's much less stringent. And there are first generation, many trials, but I would like to discuss the last trial, which is a Euroski trial, which is the largest stoppage trial. 821 patients with very less stringent criteria. So you can see MR4 only, not even MR 4.5, MR4 for 1 year. And the patient has to be on TKI for the preceding 3 years. And this is what they have updated recently. So at 24 months, you still have 51% people who are in TFR. And most of these trials, as you know, when they are destined to relapse, they relapse in the first 6 months. So the big drop is when you stop the drug, within the first 6 months, if they are going to relapse, they will immediately relapse. And then there is a drop as time progresses, but not as steep. So maybe we don't have to have such stringent criteria in trying to attempt a TFR. This is second line, nilotinib trial, again around 50% success rate. Same thing with dasatinib, again around the 50% mark. This is another trial which caught my eye, the UK Destiny trial, 2013 to 2015. Now, it was not just stopping the TKI, but they would de-escalate. So any of the 3 drugs, imatinib, nilotinib, or dasatinib, if they have been on it for 3 years, and they had an MR3 or MR4, it's even come down again, MR3 or MR4 for 1 year, then they would de-escalate the drug to 50%. So imatinib 200, dasatinib 50, nilotinib 200 BD for 12 months. And then they would stop it for 24 months. Very interestingly, the people who had MR4, when they went into the trial, their TFR success rate is around the 70% mark. This is the highest success rate among all the discontinuation trials. So you can see at the bottom of the last column, the Destiny is 77%. So I mean, it looks interesting. I don't know what the science behind it is, but reducing the dose for a while to half and then stopping it seems to have an advantage over just stopping abruptly. Multiple trials looked at what are the main factors which would predict success of TFR, and I'll read out the conclusions. So some of these trials, the first line shows the trials which said that lower SOCAL scores would lead to a higher TFR rate, but the second line shows these trials showed that there is no correlation between SOCAL scores and TFR rates. So it's conflicting data. Then the third line, depth of molecular response was a better predictor of TFR. Euroski says actually the duration of deep molecular response before TKI discontinuation and the total duration of the TKI therapy was a better predictor of TFR. TFR was lower for patients who switched to new generation TKIs because of imatinib resistance or suboptimal response than those who switched because of prior imatinib intolerance. This is a stop-2G TKI in DADI, and prior imatinib resistance or tolerance did not affect TFR rates. So lots of conflicting information from the different trials. So this is a meta-analysis from this year, and the meta-analysis concluded that these three factors are the most important with regarding to success of the TFR attempts. And the first one is duration of deep molecular response of more than 32 months before discontinuation. Remember, NCCN asks you to have a deep molecular response for 24 months. And this meta-analysis suggesting that 32 months and above has a clear advantage. Depth of molecular response before TKI discontinuation, MR5. So if you had a MR5, really deep response, it looks like they tend to be successful. And there are some studies which combines the TKI with interferon therapy. They seem to have a higher rate of TFR success rate. Okay, once you decided to stop the drug, what does the guidelines ask you to do with regarding to monitoring? So first of all, you need a reliable test. You need a laboratory which can test up to MR 4.5. And the first 6 months, you are required to test it at least monthly. So every 4 weeks, you need a test. 6 to 12 months, every 6 weeks, and thereafter 3 monthly. But if there was a rising BCR-ABL titer, then you go for a monthly test. This is another trial just to illustrate the fact that although most of the relapses happen in the first year, within the first 6 months, you can have late relapses as well. Although not as prominent, you can see that people are dropping off even after several years. So this means that the patients cannot be discharged. You have to keep monitoring them probably every 3 to 4 months. So a small subset of patients who lose the deep molecular response. So once you stop the drug, they lose the deep molecular response, but they might not need restarting the drug because it's just fluctuating. It just fluctuates between MR4, MR3, comes back again, and keeps doing that. So this is thought to be due to the, even when they reach MR5 levels, you have leukemic progenitor and stem cells present. But the cellular mechanism, such as immune system, is able to take care of this low level of leukemic progenitor cells and keep it under control, and they can continue to remain off the drug. This is a typical patient in whom we have stopped the drug, and within the first few months they have relapsed. Most of these patients, they regain the major molecular response and deep molecular response within 2 and 3 months, respectively, when you restart the TKI. So this is an individual patient, the first one shown. So within a few months, they will reach the deep molecular response again. That's a group of patients. As you can see, within the first 6 months, most of the patients have gone back to deep molecular response. Only 1 or 2 are lingering along, and it takes longer for them to achieve deep molecular response again. Another thing to be careful about is TKI withdrawal syndrome. This mainly consists of musculoskeletal pain, and in most cases it's transient, and you can see it in up to 30% of cases. This particular group looked at the pharmacovigilance data from STIM2 and Euroski trials, and they looked at close to 450 patients, and it was reported in about 102 patients. 100 after imatinib and 2 after nilotinib. That's about 23%. And what did it involve? It involved bone pain, joint pains, and arthritis. It affected the upper limbs, shoulders, and cervical spine. In about 62.5%, it was grade 1 or 2, and the remaining grade 3 or 4. How did they manage them? With non-steroidal steroids and by local infiltration. Please be aware that the median duration of the syndrome was 7 months. So they can go on for a few months, these symptoms. And if we had to restart the TKI, the withdrawal syndrome will disappear in 50% of the cases within 3 weeks. This is another thing to watch out for. So this is from this year's ASH, a poster, which says that in people who we discontinue TKI, 20% of people said, I got some psychological and emotional support from the physician. They told me what to expect and so on. 57% said, no, I didn't need any, I'm fine. But around the 25% mark, they said, actually, I wasn't expecting these symptoms after that, and the anxiety and fear of whether the disease would come back. So I would have appreciated if I had got some psychological and emotional support from the physician. Okay, moving on to the long-term impact of treatment-free remission. We all know that the incidence of CML is increasing. So this is the data from the US, or projected data from the US. US population is around 327 million, which is about 10 times our population. And incidence there is 4,700 per year. This is Saudi statistics between 1999 and 2013. And if you add these two columns, which is CML NOS and CML BCR-ABL positive, you're looking at around 14.2% of all leukemias, and a total of around 1,250 cases between these years. In 2015, we had 99 cases of, close to 100 cases of CML diagnosed in that single year, 2015. So we are looking at about 100 cases, if not more, new diagnoses per year in the kingdom. This is US data about cost of treatment. In the beginning, so this is the box down shows the CML, hematological malignancies, and general illness. So you can see that the cost of treatment for CML is considerably higher than other hematological malignancies, although the outpatient drug cost is the main factor. So if you look at all the years, $48,000 as outpatient drug cost out of the 82,000. So you can see that the drug cost in CML is clearly significant. This is the drug cost pattern in US. In 2001, when imatinib came into the market, the price was $26,000 per year. And when it was coming off patent in 2016, by that time, the cost of treatment had increased to close to $120,000 per year. And you can see in the orange graph, after the generic came in, it has come down, but not that much in the US. And still the cost per month is between 10 and 11,000. But this is not the case in Saudi Arabia, fortunately. There is a huge price difference between the first generation and second generation. When I say first generation, I'm talking about Gleevec. I think Novartis is now even competing with the generics. They are reducing the price to such a degree that, they are even lower than the generics now. I don't know if it is true for all hospitals, but this is what I got from my hospital. And look at the difference in price. So yearly price of Gleevec is 25,000 Saudi Riyals as against 160,000 Saudi Riyals for the second generation. So there is a lot of cost savings if we were to go for TFR and TFR success. What about symptoms when you stop TFR? So this is a trial called the LAST study, which is life after stopping TKIs. And you can see there is a clear improvement. So you can see the line in the middle which says 0 at the bottom. There is a clear improvement in depression and diarrhea when you stop TKIs, and fatigue as well. Sleep disturbance, marginal improvement. But the pain interference, which is probably due to the Tki Withdrawal Syndrome, hangs on for a little longer in the case of TKI withdrawal. The majority of patients, another study showed an improvement in quality of life after TKI was discontinued. So I have a few real-life TFR cases just to go through them. First one is a 53-year-old lady. She was diagnosed with chronic phase CML in 2011, started on imatinib. She achieved MR4 or MR4.5 by October 2011, pretty quickly. And then she remained in that for 3 years. She discontinued imatinib after about 3 years for conception, but she never started. So this is before the concept of TFR and trials, but she never started. And these are her latest results in 2019. She remains still in MR4.5 and MR5 without any TKI. Another 52-year-old lady diagnosed in 2002. She had intolerance to imatinib and she stopped it in 2010. She also had multiple sclerosis and had interferon previously, but nothing after that. So it's not because of interferon that she's remaining in remission. But you can see the latest results. She's still remaining between 4.5 and 5 without treatment. Another 58-year-old, this time we stopped it on purpose after 2 years of MR5. So from 2016 to 2018, we monitored her, and in 2018 we stopped it, and she still remains in MR5. So it's 1.5 years now since stopping, and she hasn't relapsed. 55-year-old man stopped in 2016. Still, but this one was, so he had a relapse, okay. So he stopped in 2016, and by 2018, the BCR-ABL had started going up. And we reintroduced nilotinib, but then he took it for a few months, and then he's lost to follow-up now. 63-year-old gentleman, we stopped in February 2019 after 5 years of MR5, still in MR5. Another successful case, a 54-year-old, MR5 for 3 years, and we stopped in July 2018. We are 1 year and probably 3 months, still in remission. Another case, 61-year-old, MR4 for 3 years, stopped in November 2011. This was due to stage 4 CKD. And he had a renal transplant in July 2016, never restarted again, and still continues to be in remission. Another one we stopped in January 2017, continues to be in remission. This lady has sickle cell anemia and CML. We were forced to stop her drug when she became pregnant, but she immediately had a molecular relapse, and we monitored her throughout pregnancy without giving her TKI, because although she lost her MMR, it never crossed the 1% mark during her pregnancy. So we just kept on monitoring her until she delivered, and she breastfed for a couple of months. And by that time, it had started going up again, 4.2%. And then we restarted it, and she regained MMR very quickly. And the last case is a a lady who we stopped as a part of the trial on in November 18, but she lost MMR in February 2019. So within 4 months, she relapsed. So she's back on the drug and she has regained her deep molecular response. So that's my experience with TFR, and thank you for listening.
Excellent, Binyam. I think I do have other cases, so it will be ideal if we combine, I'm sure Naif and Dr. Zaid and Nahla, we can really combine and present the treatment-free.
It will be a good idea too, our experience.
Thank you, Dr. Usman, for the wonderful presentation, as usual. Just one simple question. These patients, when we introduce TKI, they have a myalgia and all. And at the withdrawal also, did we check seropositivity for the rheumatoid arthritis? Or maybe these drugs responsible for the like SLE or rheumatoid arthritis like syndrome? As we know, many drugs.
Very good question. Sorry, I haven't, although I collected all this data, I didn't look in particular into the individual cases. So I don't know the patient who I mentioned had myalgia and stopped the medication. I haven't looked into detail because she stopped it in 2011, much before I started seeing her. So I don't know whether she had investigations for rheumatoid conditions.
If these are the local patients, then we should be very careful monitoring the vitamin D level, because we have a lot of the population with a low vitamin D level.
Very true. Whichever patient I test vitamin D on, they are all deficient, so very true.
Thank you, Dr. Usman, for your presentation. I have just one question about the log reduction and the BCR-APL-IS. So I saw in one of your slides that you can just compare to the IS to the log reduction, because previously we used to monitor the log reduction and now we are using the IS. So is there any relation between the IS and the log reduction? You can easily compare between one and another?
You can, because as you know, as the years progress, the detection sensitivity of the tests improved. And even in our hospital, we started reporting the test according to the international IS standards, because that is what the ELN wants everyone to do. So the reporting changed, but there is a clear correlation between log reduction and MR and the percentage. You can work it out.
Thank you.
Dr. Usman, just a question regarding the high sukar, like a high-risk patient, like using sukar or any scoring system. What's the percentage, the success rate in those specific population? Mainly because we face this in young population a lot. High risk, they ask you to stop this medication after they achieve the deep molecular response.
So in some of the trials and in that meta-analysis I mentioned, they say that whatever the SoCal score, the TFR success rate doesn't have any bearing on whether you are a low-risk SoCal or a high-risk SoCal. But as you know, NCCN recommends that if you are intermediate or high risk, you basically start on a second-generation TKI. But the TFR success rate doesn't seem to be affected by the SoCal score. This is what I could understand.
Any other question? So thank you, Dr. Binyam. Thank you, Dr. Musa. We have reached our end of program. So thank you.